Thanks, John.
Hmm.
Eric, how you doing?
Doing good.
Good. There's some talk of kind of going over like more shoulder and upper extremity integration stuff. We've done a fair amount of lower extremity rolling into module 8. Maybe a good time to review some of the shoulder and, kind of think about clinically how we look at, also about talking about how people move, but then we can diverge if people have questions or if there's anything out there that you just don't quite understand, like to have cleared up. Be a good time to do it. Let's try and get as many of you involved in here as well in this discussion. So, Eric, I was figured start off with just talking about maybe some of the stuff with the rotational athletes when we look at the shoulder and then just start kind of going through the system and thinking about in the kinetic chain.
Yeah. Okay. So, um, rotational athletes. So if we're looking at something like overhead throwing, it's very much a rotational event. I tend to break it down into a certain number of body units when we kind of evaluate this sort of stuff. And some of that has a little bit of kind of differentiation on where things start, where things end. So usually looking at the shoulder girdle, we're looking at anywhere from, about T6 up down to the glenohumeral joint, right? And then everything beyond that's going to be kind of quote unquote arm stuff. Um, and I will tend to look at pretty universally the TL junction in rotational athletes, basically because it's the where most of the trunk rotation is going to occur anyway. So as far as the process goes, if somebody comes in, say you have an athlete, so that, say it's we'll make it simple, it's a baseball pitcher, comes in with complaints of shoulder pain. Let's call it anterior shoulder pain. It's going to be the most common symptom that we tend to see. The process doesn't really change from anything that we've done previously. As far as looking at athletes, the idea is if somebody comes in, they say, okay, let's call it a 21-year-old college pitcher comes in complaining of anterior shoulder pain. Immediately, the thought process should still go the same way it usually does. What are a handful, two, three, maybe four hypotheses as far as the diagnosis goes that immediately come to mind? For me, I'm looking at bicipital tendinopathies. I'm looking at AC joint dysfunction. I'm looking at labral pathology. Right off the bat, there's three right there, right? And so when you start to go into your subjective examination, the process should be, again, very, very similar. How do we differentiate these things? What phase do you tend to feel the discomfort in? If it's going to be, kind of more into a closed pack position here as they're going into acceleration phase, you're probably looking more at either the labrum or the biceps mechanism, right? Does it come with clicking or clunking? Again, that's going to lean you more toward a labral pathology. Is it worse with compression, right? So reaching across the body with follow through, things of that sort of nature, laying on that shoulder at nighttime. If those things reproduce it again, we're going to start leaning more toward an AC joint dysfunction. So the questions, especially in the shoulder, in my opinion, can tend to be very pointed, very direct, and they can start to sway those probabilities from one hypothesis to the next. And as soon as you're starting to think, okay, I'm pretty comfortable, I'm in that 75-80% range where we're usually at to start going through an actual physical exam. Um, then you can go in and do some differentiation tests, some confirmatory tests. If you're thinking, bicipital tendinopathies, we can do a biceps load test. We can do digital palpation. We can do a handful of things there. If it's an AC joint lesion, we can do cross adduction. We can look at palpatory techniques there as well. If we're looking at labral stuff, we can look at a load and shift. We can look at various different tests for the labrum as well. And you start to kind of look at it, say, okay, these tests have come up positive. Now I'm really comfortable saying that this is the pathology. I do tend to think from that point on, most of the examination is going to remain very similar, regardless of what your differentiation tests show you. So once you find your diagnosis, most of the further examination, the biomechanical exam, is going to end up being pretty similar because especially in overhead athletes, most of the issues are either going to be a loss of CT junction upper thoracic mobility, a loss of what would you call it, shoulder girdle coordination, which tends to be something that's affected by cervical issues, things that affect the motor coordination of the parascapular musculature and how the scapula is able to kind of function and move relative to the thorax and relative to the humerus. Um, and or we're going to end up finding some sort of instability, but an instability in, say, the glenohumeral joint is often going to be caused by a hypomobility someplace up the chain, someplace more proximal to that. So again, I'm pretty much going to go directly into looking at CT junction, mechanical biomechanical exam. Then I'm just going to kind of work my way distally. I'll go into the shoulder girdle, AC, start looking into potentially scapular mobility, whether or not we have changes in motor tone that might affect the scapular quadrants. I showed you guys that stuff during module 7. Um, and then after that, we'll look at the glenohumeral joint itself, looking for passive mobility, stability, and then some different types of shearing tests and things of that sort of nature. And may need to go in and do some tests for AC joint stability. So we're looking at the costoclavicular ligaments and things of that sort of nature. If we have to. It kind of depends on what the diagnosis is. If we find AC joint pain as our potential diagnosis, we're going to want to look at stability for the AC joint as well. So realistically, the examination process doesn't vary a whole lot in that sort of scenario, depending on, regardless of what the diagnosis ends up being. Unless you find somebody that comes in with like posterior shoulder pain or something along those lines. But most of the time, these things are going to end up being very similar with just a few very subtle variations that come in there. You do I'm imagining you're doing a pretty similar process for
Yes,
shoulder
it's pretty
stuff anyway.
similar. It's developing, okay, what is my working hypothesis and differential diagnosis? But then yeah, as you work through the systems, it's part of it is an etiology search and bias correction. So knowing that, okay, I need to know how the thoracic spine is going to move, CT junction, understanding scapular, biomechanics, but then that's also related to, again, cervical influence on that as well, or physiological influence. Because, okay, I had scapular dysfunction. It's like, okay, where's this driving? Is it aberrant motor pattern, or is it something coming from the cervical spine? So, you know, it feels overwhelming at first because you have all these places we just said, but really it comes down to it's like, okay, I've got anterior shoulder pain. Can I localize the source of it? And then now I have these different areas or buckets for my etiology search. And that's kind of what Eric is talking about is understanding these different relationships. What does the CT junction give me or the TL junction give me, or what doesn't it give me? And then working your way in the shoulder, elbow, maybe eventually even wrist if you're looking at somebody who's throwing and going through the quarter. But it's kind of like going from the shoulder out. And I guess, Eric, many times for you, it's like you get this sense of, okay, this is a shoulder, but I feel like it's the thoracic spine. I'm watching them move early on or seeing something. You get a sense of, I think the driver is over here, and that often will dictate our exam. I guess that's
Yeah,
like
I mean,
probably how you move.
when I do it, I look at it from a perspective of what's going to be the easiest for me to work on, right? So somebody comes in, they're saying, "Oh, I've got shoulder pain, and I'm an overhead athlete." Okay, well, the first thing I'm going to say is I'm hoping that it's going to be a CT junction issue, right? Because I
Mm.
can work on CT junction issues. They're easy to fix. Manipulations do really well in that general vicinity. Carryover tends to be the harder part of all of that stuff and maintaining any mobility that you might regain from there. The thing that I don't want to end up seeing, just from my own perspective, is I don't want to end up seeing changes in the periscapular muscle tone because it opens up that whole other can of worms of having to look at the cervical spine now,
Hmm.
right?
Correct.
And that may or may not change things as far as whether or not I'm going to have to treat the CT junction because dysfunction in the CT junction or loss of mobility in the CT junction can very easily irritate the lower to mid cervical spine, right? And so those things can affect muscle tone very easily by creating segmental facilitation. So that affects all kinds of things. I mean, we talked about it in class brief. I forget which course it was, which module it was where we did this, but we were looking at kind of the clock component of the scapula and how basically every level of the cervical spine is represented all the way from a cranial nerve with the traps down to, C7, C8, affecting things like pec minor and whatnot, right? So portions of the serratus anterior. So we tend to have every level of the cervical spine represented in a basically a circular motion going around the scapula. So when we start finding those things, it's just like, oh man, that just ends up taking us into a whole different realm. And it may have to go that way anyway. But when you start in, you start seeing, okay, well, there's loss of mobility in the CT junction. Okay, that at least we have something that we can start working on here. How does that affect clavicular position, right? Because obviously, if we have a CT junction issue, the collarbone sits on top of the first rib, right? And so if we have an alteration of position, right, we're kind of dumped forward here on one side or rolled forward here on one side, or we have a ring shift where things have kind of rotated, things of that sort of things of that sort of nature. So it's like, well, what does that do to the clavicle? How's that going to affect the ability of the AC joint to function appropriately? Think of it, if we think of the AC joint almost like an analog to the SI joint, um, we can obviously have more what we would call primary pathology of the AC joint compared to the SI joint. Remember, going back to the SI joint, it's such a stable articulation that it doesn't typically have a lot of what we consider primary pathology, where it becomes dysfunctional on its own, right? So stable, even if you fall on your butt, you get hit by, you're playing a sport and you get tackled, you get, so an impact, something like that. It doesn't tend to create, movement dysfunction of the SI joint in and of itself because it's so stable. So we need those external forces, things like, mid-thoracic or TL junction issues, hip problems beneath it. These are the things that kind of tend to slowly drive the pelvis into abnormal positions, and that's where most of those um, SI joint issues that are secondary SI joint issues, that's where most of those things come from. The AC joint's an analog to that in the shoulder girdle, but because it's not as stable of an articulation, right? It's just not as heartily put together as the SI joint. We can have more primary problems in the AC joint, but we also will have those external driving factors like CT junction issues, for instance, like cervical spine facilitations, things of that sort of nature that may affect position of the clavicle or the scapula relative to each other. And that just eventually ends up affecting how the whole shoulder girdle functions um, during a particular task, like overhead motions, for instance. So looking at those sort of things, that leads us to do a little more positional testing. Um, at least me, I do a little more positional testing in the shoulder girdle than I typically will elsewhere in the body. Just because I tend to think positional testing a lot of times is it's not as reliable as what we'd like it to be. Um, but I will look at, kind of where does the clavicle sit relative to the opposite side? Is one side significantly rotated, anterior, posterior? Where does the scapula sit relative to the other side? One of the ones that I'll look for probably the most consistently is I'll just put my thumbs on the superior medial angle where the levator scap attaches, just kind of put those right there, and I'll look for asymmetry there. That could tend to suggest that there's a facilitation of the levator scap. If that's the case, I'm pretty certain there's going to be a cervical facilitation coming out of play there, probably 2-3.
It's a common one I would see in the combination.
Yeah,
Usually I'm going to go up
it's
to two,
it's
three.
super common, right? Super common. Um, and that opens up another whole can of worms because when we start seeing C2-3 problems, now we've got craniovertebral influence that we might have to start looking into, right? So
Mhm.
again, you start finding tone issues or tone changes around that scapular region, you're going to be in for a bit of a witch hunt, I think, when it comes down to it, as far as looking for etiologies go. But it's doable. It's definitely doable. There's a sequence of things. I tend to look at it from a sequencing perspective. I don't want my patient having to get up and down a bunch of times, so I'll tend to try and do everything that I need to do in seated first, And then I'll move on. So whether or not that includes, cervical mobility to active mobility testing, things of that sort of nature. And then I'll go into supine, and then I'll go into side lying. And if there's, maybe once or twice here and there may be something I need to do with them in prone. Um, but if you can kind of sequence those things out and understand the things that you have to do in those sort of positions, you can kind of get through everything you need to. Um, but there is kind of a sequence to these sort of things, and we can kind of talk through that if you guys want. Anybody have any particular questions about that process right off the bat?
I just
Things you're
threw a bunch
seeing?
of the sequencing into the discussion board, kind of in order. Some, as I thought of them were a little out of order, but seems like a lot at first, but it's kind of what rolls through our minds as we're looking at somebody. Like, each one of you knows how to look at every one of these regions. And this is kind of how you would work through it if this was a picture, eventually pulling it all together.
Yeah, I mean, I would say the the TL junction stuff ends up being pretty high on the
Hmm.
list, right? Just because, even ahead of things like elbow and wrist, especially
Hmm.
for overhead athletes or rotational athletes, just because there's so much rotation involved. And if you can't, in most cases, outside of it's usually like volleyball players or jump serves in tennis, where they actually are producing a lot of their rotation when they're in the air. Most of these things are caused by direct contact of ground reaction forces coming from the lower extremity up through the TL junction. So if you don't have adequate mobility there, adequate ability to transition the forces from your legs into the trunk, then you have to make those forces up somewhere along the line, right? So um, I've seen this a ton. I've seen this I think it happens more often in actual throwers. So quarterbacks, pitchers, et cetera, those sort of things, where we end up trying to add that energy back into the system via the trunk, the ability to move in the trunk. And that's where sometimes you'll start to see patients that'll come in um, as far as throwers with oblique strains, things of that sort of nature. And it's just like, how did I get to this sort of thing? It's, well, odds are you have a TL junction issue. It should make sense because now the pain, it's not shoulder pain. They're coming in with actual abdominal pain, or trunk pain, where it presents, potentially even like pubic pain, right? Where some of these muscles will attach. So TL junction ends up being a lot higher on the list than what you might think it would be, but it's a very important spot to look for.
Yeah, I think TL Junction be up there. And even here having ankle and foot at the bottom. I mean, honestly, they would probably
Yep.
leapfrog that too. I'd be looking at the rotary joints, which would then be TL junction, probably then hip, ankle. So where it'd be generating a lot of the rotation and anyone moving. Again, it's, you take the same premise. If you're not seeing athletes, it's fine. Think of somebody who's walking or doing something around the house in a reaching task. We looked at that like different reaching tasks in module 8. And just that idea that, we're talking about rotational athlete, but don't dismiss, well, I don't see athletes. It's really going to be how we move and how we do it and how we transfer energy through the system.
Yeah, I mean, one of the ones that I'll see a lot, maybe I don't see it a lot, but it just comes to mind is somebody that does like stocking work. So, somebody that goes to works at the supermarket, and their job is to take boxes of things off of a pallet, turn and puts things overhead, right? So there's that lifting, you're now all of a sudden you're loaded, rotation, and then shoulder girdle movement in order to get things overhead. It's different than the high velocity components that we think of when we're looking at athletes, but it still requires the same type of function, right? Through the shoulder girdle, through the glenohumeral joint, through the trunk, an adequate neuromuscular coordination, which would also come out of the cervical spine, et cetera, right? So any one of those sort of things, you can think about all kinds of different scenarios where these things play a role. But the idea is you have to pick out what this task is that they're having problems with, right? And so Dave and I have talked about it plenty, especially on these calls where Diane Lee calls it a meaningful task, right? And she has this whole thing where she puts the circle up on her um, evaluation sheets, and like in the very center, you write down the meaningful task, and then you start splitting things off onto where the components are supposed to come from and things of that sort of nature. I never found it super helpful to do that sort of thing in the clinic. Um, but when you when you're looking at this stuff, maybe it's not a bad idea to just at the top of a page, if you're taking notes or if you have a tablet out or your computer out with you or something like that, and just at the very top, you just write down this is what they're, it's basically like listing a functional limitation, right? Mine and
Yeah,
my
it's a functional goal, and
right.
kind of
Yeah.
keeping that
So
as in the front of your mind, like this is what they can't do, and then what's the component of that task.
yeah, correct, right? So mine in my documentation, functional limitations and evaluations are more down toward the end. They're after all my objective stuff and whatnot. But it's not a bad idea to have that stuff right up at the top because so you can go back and look at it and reference it and say like, yeah, this is where this person needs to get to. I need to figure out how they do this, like how does their body achieve that task? And then I can start looking at the either I can look at the motion myself, right? So if I'm looking at a thrower, um, gets a little tenuous sometimes if it's actually painful with throwing. Do I really want to take them, out into the gym here and have them start throwing if it's going to hurt them? Or reproduce pain. It's just like, yeah, looking at the mechanics there maybe isn't the best, but you can certainly break down the mechanics individually into the various body regions that you need to examine. And I will do that a lot because that's what I'm going to do eventually anyway, is I'll skip right to that sort of thing rather than looking directly at that task. Now, definitely would recommend if you can look at the task, then you should, because there's a lot of things that happen at high acceleration points that you may not recognize during, more isolated um, movement testing, right? So when I'm asking somebody to do something with their shoulder girdle here, lifting overhead, doing abduction motions, cross adduction, it's like, yeah, it tells me a little bit about how things are functioning. But you find things at speed at high acceleration points that you just may not notice, right? And so facilitations are definitely one of those because we look at speed dependent weakness being one of the major things that we can test for to show us that a facilitation is present objectively, right? So when we're thinking about that, when somebody's throwing, like it's one of the higher acceleration, higher speed motions that the body can produce. It's just like, yeah, you kind of need to be able to examine these things at speed like that. Now, maybe that means breaking it down and looking at, other things that we can test for, right? So the ability of muscles to lengthen, or scratch tests, all these different things. Maybe even looking at distributed weakness, velocity dependent weakness into the limb, because it's not real easy to do it around the shoulder girdle, particularly if we're looking at parascapular musculature. But you can say, well, I need to look at, say a C6 muscle for potential facilitation. Well, I would just go right down and test the wrist extensors and not worry about having to do it around the shoulder girdle. Because in theory, we should be doing that anyway by testing a secondary muscle, a second or an alternate key muscle in order to
Mhm.
determine, yes, this thing does appear to be segmental and not uh, peripheral, right? So we're not looking at a peripheral nerve issue. We're looking more at a segmental nerve issue, which would lead us more toward the spine, right? So those things are all things that we can do in order to look at these things. And, sometimes I will say sometimes the most convincing confirmatory test is the one that just kind of pops into your head after a while. Like, well, what else could I do to look at C6 here? Like, well, I go down and look at the wrist and see if the wrist extensors are having issues. Do I see a facilitation there? Those little things sometimes pop into your head at just the right moment, and you go and you do it, and you say, well, you know what? If it's affecting that, it's definitely going to be affecting these other components. So we can kind of work off of that as far as our examination process goes. But yeah, I mean, I think it in general, examinations should have sort of a outlined process. Like so for instance, we talked about for the lumbar spine, I put it up on the board, we run through it, check through these things and see how you go. And it's literally I think it's 1 through like 11 or something like that of different things that we would do. Um, but basically as you're going through the process, you start realizing, well, I don't see anything, I don't see a limitation of seated rotation, so I can take the TL junction thing right off the board right away. I don't have to go through and do that stuff. It's the exact same thing with the shoulder girdle, right? So we want to be able to use the idea of screening tests to determine, is there something here that makes me think I need to go in and do a full biomechanical examination of this. So again, looking at seated rotation, for instance, if I'm concerned of a TL junction problem affecting potentially how we're able to generate force into the upper extremity. If I look at that and I'm like, you know what, there's no difference one side to the other here. They both look like they're moving very well. I'm going to just take that. I'm going to cross it off the list. You take, what is it here on Dave's list? Number 8. You take number 8, you just put a line right through it and you say, if I have to, I'll come back and look at this later, but right now I'm not concerned about it. Same thing with the CT junction, same thing with the shoulder girdle itself, ACSC, et cetera, glenohumeral joint. We can find ways to screen these things in order to do that. So for the CT junction, usually I'm going to look at respiration mechanics. I'm going to look at cervical motion mechanics, right? So just probably 2-point palpation, going through those motions. For the shoulder girdle, I'm typically going to look at shoulder quadrants, right? So that's going to be kind of elevation, depression, protraction, retraction, and I may do combined movements into, say, protraction and elevation or depression and retraction. That'll tell me a lot about what I need to know about the AC and SC. And then for the glenohumeral joint, we can look at active motion. Problem with active motion is that it's going to combine in all the CT junction components. It's going to combine in all the shoulder girdle components. So we can do, I'll usually do some sort of passive mobility testing there, whether that's shoulder quadrants or just looking at fixed scapular positioning and then going through passive mobility testing of the different movements of the shoulder of the glenohumeral joint itself. Those are kind of just some simple screening tests that we can use to just look and say, okay, do I need to go in and do a deeper dive here on these things? But it's very similar to how we would do things in, say, our lumbar exam components, right? If you screen something out and you're looking at it, it's like, no, the screening test looks pretty clean. We do a Portland test, for instance, for the SI joint, and that comes back clean. I'm probably not terribly concerned about concerned about the pelvis itself at that point being a driving factor for lumbar pathology, right? So what do you think, Dave? How do you do that sort of stuff?
Yeah, I mean that's the way you go through it in a sense. And as you said, I think the hardest part when you're translating from where we are now to where you end up, hopefully after the next 2 months, is that yeah, wow, there's 12 things on here that gets to be kind of intimidating, or 13, but you realize that okay, some of those are coming off the board rather quickly with your basically screening test and examination. Some you aren't even thinking about because you're just not seeing it in their motion. So as we see that how we're going to screen and look at this individual, you're going to have certain areas that are going to be more focused. And then, what generally happens sometimes is you're not coming up with something. So I don't find anything at the CT junction or thoracic spine that's kind of leading me to think it's there. So I'm kind of moving down TL junction. And he's actually right, lumbar spine into the SI joint and hip. Really once I get past the thoracic spine there, I'm probably going to go TL junction. I'm going to look at hip SI joint and then foot because those are my rotary joints of stability in this individual. If it's throwing or a rotational task, those are the joints, whether do I have a restriction or do I have hypermobility or uncontrolled motion or an abnormal motor control program that's running through this. And so it's getting that sense that, hey, don't get overwhelmed by, hey, I have to look at all these things. You're right. Wrist is probably an elbow, and they may be down on my list in this individual, unless there's something clearly going on when I watch them move. If I see them and they've only got, 20 degrees of wrist extension, okay, that's a problem. And, now I'm looking in the upper quarter a good bit, because they're going to be compensating at the shoulder probably for that loss of motion. So it's really going to kind of lead itself. But right now, at this point, we have the ability to look at these joints very, very closely and get a sense of articulately, can they move in the right pattern the way they need to? Do I have any limitation? Now, can I control it from a motor standpoint, neurophysiologically? Or do I have an altered brain map and movement? And then why is my brain map altered? Is it pain somewhere else? Is it past experience? Or I developed a gimpy pattern that needs to be corrected?
Let's see if
So,
this pops up the way it should.
yeah. And this pattern is universal, whether we're talking about an ankle problem, we're going the same way. Now, we're not at risk with an ankle problem, but from a shoulder problem, we can go either direction.
So I put the process that I teach during my throwing course in the chat there. So you guys can look at it if you want. It really shouldn't look that unusual to you. how do we go through this whole process? And this is it, right? We start with a subjective exam, pointed questions. We want to differentiate our hypotheses. We've talked about this, right? Then we have our differentiation tests, right? So these would be specific tests to basically determine what our pain producer is, right? Which tissue is it? Is it the biceps tendon? Is it the labrum? Is it the AC joint? Is it a rotator cuff thing? Is it more joint capsular problem? Is it blah, 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 et cetera, right? So we do those, and then we're going to go into those screening tests that we were just talking about, looking for etiology, right? So look at the various units. So this mentions throwing motion because that's obviously the course that it's coming out of. But basically, you're just looking at the various components of how this person produces the task that they're having trouble with, right? So when we're looking at gait, what are the things that have to happen? What body regions, what joints in this particular area are involved and how do they function, right? So we look at screening tests just to see how they're functioning, right? Well, this one looks like it's off, right? So, oh, we've got a positive Portland test. Well, that's clearly an issue, right? Is it the primary problem? Well, in general, SI joints are not going to be the primary problem. Okay, well, so that's an etiology thing that we have to go chase down, right? But these should be very brief examination techniques, things that you can run through quickly just to see if there's an issue that requires further investigation. Once you find those things, then you move down into the biomechanical exams, right? Wherever you find dysfunction, wherever you find things that aren't functioning properly, now you're doing a more in-depth dive to essentially figure out what can we do here in order to fix these things up and get this person functioning more appropriately, right? So hopefully that helps with the process. And like I said, some of these things you may just cross off the list and bounce out of the whole, but shouldn't be terribly difficult. All kinds of funny stuff popping up on my computer. Um, all right. What else do we want to talk about here as far as this goes? You guys have questions here? Anything specific about particular components of the shoulder girdle? I forget who was it that wanted to go through this stuff. My
It was
suspicion.
me.
There it is. I
Yeah,
kind of figured. I figured.
I was just going through the stuff and the information that was given, there's just so much compared to every other joint that like I was getting so overwhelmed, but this is helping. So thank you.
Yeah, well, and here's the deal: it is a little overwhelming, right? Because we have to consider so many potential areas, right? So CT junction's got its own list of problems. The shoulder girdle itself, and when I'm talking about shoulder girdle, guys, I'm really just talking about because you would technically consider the CT junction a component of the shoulder girdle. But when I'm saying it in these sort of situations, I'm really looking at it as more it's the clavicle and it's the scapula, right? So that's just kind of what I'm trying to get across with that. And then the glenohumeral joint has its own, slew of other issues that comes about as a result of these potential issues. But realistically, I would say it's probably 90% of the patients that come in with shoulder dysfunction, whether it's pain or difficulty with producing a particular task. um, you're going to look at most of the same things. You're going to look at CT junction. You're going to look at the AC, SC potentially. SC probably notably less than the AC as far as frequency of how often you have to look at that. And then you're going to look at the glenohumeral joint. And you're just going to try and associate how the problem that the patient's having may react or may be affected by those particular issues. I think for me personally, I think the neck is the biggest complicating factor here because it can affect so many other things. I mean, we could have pain that's directly coming out of the neck that's just, hey, my pain is right here. They start pointing into this area. Some people might say that's the front of the shoulder. Some people might call it the lateral shoulder or the distal portion of the shoulder, or whatever it might be. But it could just be a simple segmental facilitation of, say, C5 that's affecting the insertional point of the supraspinatus. And that's all it is, right? So there's nothing actually going on in the shoulder here. It's all coming out of the neck, right? But we should be able to differentiate that based off of multiple different factors, right? So When we look at the CT junction, maybe their screening tests come back pretty clean. I'd say that's pretty rare, but maybe it
Mhm.
happens. We look at movement tests of the scapula and the clavicle, and maybe they don't look too bad. Again, probably would be pretty rare given the idea that we would have a facilitation of C5 because that should also affect parascapular muscle tone, and the ability of those to lengthen. But these are potential problems that could come up, or we could have a pure reference pain, right? Just a pure referred pain that doesn't even have a local tenderness, right? And those sort of things are definitely possible. We see it in the hip actually quite a bit, where we have um, kind of lateral hip pain is kind of a very similar thing that's being caused by an L5 issue. But we can't seem to reproduce it with resisted testing of, say, the hip abductors and or palpatory tests, right? These things do happen. So, um, in general, I think the shoulder can be simplified if you have a good process, right? So, like I said, I'm going to go right through my subjective stuff. I'm going to go through my differentiation tests to see if I can figure out what's painful. Then I'm going straight into CT junction. I'm going straight into clavicular and scapular movements. Then I'm going into the glenohumeral joint. And wherever I find problems, I'm doing a detailed biomechanical exam of each. Sometimes it's all three of them. Sometimes it's all three of them and the neck, which really at a certain point when you're sitting there in an exam, you're kind of going like, do I really have time to do all this stuff? Well, maybe you don't. Maybe it's better option to just go through the CT junction stuff, look at the shoulder girdle stuff, glenohumeral stuff, clean all that stuff up, and see if that helps to improve potential neck issues, right? And then you can come back the second time and start seeing, okay, now what am I finding? Because the cervical spine stuff in general, if we have CT junction issues or if we have shoulder girdle issues, we're going to find reflex or, quote unquote, regional inhibition of most of the shoulder musculature anyway. So it potentially can cover up any cervical spine influence because we're not going to get past that first repetition on the kind of 5 to 6 repetition force output testing that we've outlined, right? If we want to look at that sort of thing real quick, force output testing, we're looking at on rep number 1, if weakness appears and it's this breaking type of weakness, it's probably a local problem, right? It's probably local to the joint that we're testing around, and or it's a regional issue that's affecting maybe the girdle, that might be associated with the joint that we're testing around, right? So that would happen on the very first repetition. If it happens on the second repetition, more than likely this is going to be a fatigable issue, right? And it's going to continue to be weak from reps 2, 3, and beyond, right? If nothing happens on those first 3, then I'm going to tend to switch gears and I'm going to look at doing velocity dependent testing. Okay. And I may do 2 or 3 different repetitions of that just to confirm what I'm finding. As far as the speed dependence goes. So we can be doing upwards of 6 repetitions for force output testing consistently. Now, if it happens on the first one, well, then we can't really test for neurological weakness because we can't do repetitive testing. We can't test for velocity dependent testing because we're never going to get to the point where we get through the first 3 repetitions without something popping up, right? So we essentially at that point we have to eliminate the local problems in order to determine is there some sort of descending influence coming from the spine here, in these cases the cervical spine that might be affecting things. So a lot of times that's just what I'll end up doing, and I'll do the same thing in the lumbar region or in the lower quadrant as well, because it's just like, well, I can't really test for these more significant descending issues as long as there's these local pathologies, local problems, kind of gumming up the works, if you will, as far as doing some of my testing goes. But again, it will depend on the entirety of what you're seeing out of the patient as far as when they come in.
Yeah, that's a good point. Is that it's not like, okay, I have 1 through 13 here. Don't feel like you need to master 1 through 13 in your 40-minute or 1 hour eval.
Mm-mm.
You're gonna have somebody who's in pain and they have local pain, and it may be their first thing is, hey, let me build a rapport with this person. Let me get them confident in me, and what can I do locally to take their pain away? And if you see something that's glaringly obvious in, 4 through 13, then you go for it. But the first point is don't lose sight of this, that, hey, let me get this patient feeling better. Me get them have some confidence in what I'm doing. Let me apply the local biomechanics to say, how can I unload this shoulder? Like, they may have a scapular dyskinesis. What's the quickest way? Or can I show them by redirecting their scapular alignment, I can decrease their shoulder pain? So they get a sense of, hey, I can be out of pain. And this person knew how to take my shoulder out of pain. That's really, really important in the initial eval.
Yeah.
And then, as you unwind them, that, hey, now we're going to go, I can work my way down to a TL junction or one of these areas. But first of all, don't feel pressured like I've got to go through all of this in my eval to get it. It's, you're not going to.
Horrible. I mean, it's totally true though, because if you're looking at it and you're going like, well, I have to get through all 13 of these things. Honestly, if you're getting through all 13 of these things, you're not doing a good enough job of examining some of these areas, right? It's just not possible to do it all at once. So if you think about it from this perspective, what we're looking for is we're looking for these like keystone faults. What is the driving mechanism here that's setting this whole thing off, right? Easy ones sometimes are the patient comes in post-trauma. Well, I fell on an outstretched arm and now my shoulder hurts. Like, well, maybe you dinged up the labrum in the fall, right? Okay, there's your etiology, trauma, right? But most of these patients don't. Most of these people come in with these insidious onset things and they kind of gradually increase into the point where they become, functionally relevant. And it's just one of those things where it's just like, okay, day one, here's kind of my most common problem areas. Let's look at these things. If I find problems in these things, then I'm going to go ahead and correct those things because I've seen them improve things so consistently. A lot of times the carryover that you get from session 1 to session 2 or session 2 to session 3 will tell you whether or not you need to look in other areas, right? Because if you have somebody come in with shoulder pain and you go and treat their CT junction, and that's the one thing that you do, and they come back and they're like, you know what, I started getting better right away, and 2, 3 days later I was having almost no pain. It's like, well, that makes sense. The CT junction is probably the driving mechanism on that particular patient, right? The patient comes back in and they're like, well, it actually did pretty well. The first day I was 60% better. The second day I was like 80% better, but it's kind of lingering right at that point. Well, maybe there's some additional factors, mechanical factors or neurophysiological factors or postural factors. We discussed this last week that are still playing a role. And then you have to kind of check and see where those things might be, right? Um, so again, we're looking for these kind of what I call keystone faults in the system here that are really driving this thing and forcing these body regions to become dysfunctional. Sometimes it can be a situation where the carryover doesn't maintain, right? So if you treat somebody's CT junction and they say, "Boy, I was great. I felt great for about 2 days, and then it started coming back." And then you examine the CT junction again, and the problem that you had there initially has come back, right? We've all seen this. I see this all the time. It's one of the most frustrating things about being a manual therapist is trying to get good carryover in the CT junction, right? In the thorax in general, but especially to me in the CT junction. The thought is, well, what made this return? Right? So is there another potential problem within the thorax that's kind of perpetuating this thing? Used to see this all the time when I used to see more overhead athletes where we'd have a CT junction issue and a concurrent TL junction issue, right? And so I think I've mentioned this previously that I used to examine both universally. Anytime I was examining the CT junction, I would always examine the TL junction. TL junction issue, I would always examine the CT junction issue. And the reason I started doing that at one point was because of how both are so affected by posture and by respiratory mechanics, right? Diaphragmatic attachment points are along the TL junction, and then things with how the upper ribs are able to move are necessary to move in association with things like the scalenes and whatnot at the upper points of the thorax. So I used to do that every single time. I don't do that anymore just because I started to notice that there wasn't that 100% correlation, right? If it's 100% correlation where I'm always seeing a CT junction issue associated with a TL junction issue, then yeah, it would make sense to do it every single time. But it wasn't close to that. It was, closer to 50-50, maybe 55-45, something like that. So at that point, it didn't make sense to continue doing it every single time just from a time frame perspective in the clinic. But sometimes you have to do that sort of thing where you say, why can't I get good carryover out of my CT junction? Well, maybe it's a TL junction issue that's affecting respiratory mechanics. And that's why I keep getting CT junction issues popping up over and over and over again. Maybe it's an instability, right? Maybe there's an unstable segment somewhere just nearby. Like for me, T4 is a very common place to have some anterior instability because of postural dysfunction, right? It forces us into a forward head posture. If we get kind of that anterior translation with extension that tends to happen from a segmental instability there in the mid to upper thorax. So those are some of the potential things that you may have to look for, right? As far as driving factors, how do I influence these things? How do I get better carryover? But again, sometimes you need to go through the full first treatment session in order to treat a few things, see how they carry over, see how it affects the patient's dysfunction, the patient's pain response, and then you can kind of build off of that from that point, right? Jim talks about it a lot, I think, in some of his videos where he's just like, you don't necessarily want to go in and treat 20 different things every time a patient comes in for a first visit because number one, say you give that patient really good relief. How do you know which one of those things you should be focused on? You don't at that point, right? It's a shotgun effect. You're carpet bombing at that point. It's like throwing napalm at something. Like, well, we don't know what the problem is, but we're just going to nuke the whole area here and see if we can wipe it off the map. Maybe you're successful, but you're never going to be able to give that person enough specificity in what they need to do going forward, right? So it's better to go in and treat maybe one, two, maybe three different potential areas, depending on the body region you're looking at. And shoulder girdle stuff, I will say I often will treat three areas. I'll do something for the CT junction, something maybe for the AC joint, and then maybe a little positional stuff with the glenohumeral joint. That's a pretty common first visit for me for upper extremity shoulder issues. But, say I start having a hard time maintaining that carryover, then I might start looking around for other problems, right? Especially if I've cleared out the neck, so maybe I'll look mid-thoracic, TL junction, maybe I'll look at the hips. It depends on what the functional task is, but that's a pretty typical process for me.
Let's talk a little further down the road. I mean, this is what we're doing initially, early going. It's getting to lay the land, what's all impacting this. I mean, for rehabilitation, it does kind of start local and local control. Can I control the scapula? Can I control the mechanics? What's my pattern? Because oftentimes these people will be left with a gimpy scapular mechanic that needs to be cleaned up. And that's kind of where you'll be looking at your centering and control from there. Okay, do I have, what can I do to facilitate serratus or lower trap or get that non-painful synergy to happen and control through the range of motion? And then it's kind of progressing, an easy way to think as we look at these different joints, it's how do I do it then challenging these other segments? And it's usually going to be rotary joints. How can I have the shoulder rotating with the thorax and working in conjunction with the thorax, cervical spine, and working down through the hips? I mean, I'll usually go with that with, looking at good control, rotation patterns and shoulder patterns, kind of sagittal plane, coronal plane, transverse plane, shoulder motions in different directions. First step would be, okay, double leg stance. And then I'm going to combine, first is like more like, can I stabilize all my rotary joints and move my shoulder and control it? Then it gets into, okay, can I rotate through my TL junction, thorax, and control shoulder? Then moving on to hip, ankle, and then adding in squat and probably single leg stance work into my shoulder. So my shoulder work if you think about how you rehab it in the same way, you can almost take this list here and say, okay, let me progress out my level of complexity once I'm past my acute stabilization phase. Because you may find if it's the pitcher or this athlete, you don't stumble into, oh, this is a foot control issue until you look at single leg stance with shoulder and rotation pattern. Or is it a hip control issue? Like they were fine on your initial tests, but you combine, I look at the pelvis in isolation, the hip in isolation, but now when I combine the shoulder with the hip, okay, wow, okay, the hip falls apart when I'm challenging the shoulder when I layer on this and seeing this. And that's going to be your baseball player where, if you look at these information in isolation, you may not get that full story. So it'll be looking at these patterns and rehabbing in the pattern of motions that you may see. And athletics is fun to talk about because it's dynamic and there's well-defined phases, but you're also looking at this in your people who walk or do anything else. Is if they have a balance control issue, the body will always prioritize the balance control issue at the expense of shoulder dynamics or upper body movement. So looking at balance and shoulder control for me is that higher level thing that I look at in most people in single leg stance or perturbations or squats or hinges, because they can't remain stable. Their body, it's going to downregulate how it sees stabilizing the shoulder and prioritize not falling on the ground or getting centered. So
Yeah.
that's your older patient, your 40, 50, 60-year-old.
Yeah, two of my favorite ones that I've ever seen as far as overhead athletes was a guy that ended up the biggest issue he had, as far as why he kept having these issues kind of crop up. I mean, he had a couple of mechanical things, but they were relatively easy to correct, and we were able to get pretty decent carryover with those. But then he'd go, this was he was a minor league pitcher, so he was in his late 20s. He'd been doing this for, obviously long time. And he would get these issues like every month or so. Like it would start to come back. What we ended up finding with him was he had a medial knee instability on his plant leg. So he was right-handed pitcher. Plant leg would be his left leg as he's going into kind of that uh, the slingshot component of it. And what would happen is his knee would wobble, and you'd start to be able to kind of notice this sort of thing. And it was just everything broke down above that, right? So everything started falling off. He started leaning in one direction. And so instead of getting his arm kind of in this position where everything tends to be more stable from the elbow up to the shoulder, is he'd start getting into this position where everything was kind of leaning away because he was basically falling over this leg that wasn't stable. So we ended up having to work with that for a little while. And once we got him a little more comfortable and a little more balance centered on that plant leg, he did great. He needed to work with a trainer a little bit on and off during their season, but it was good. The other one, and this is one where we probably don't have time to go into it today, was they had tracking issues with how their eyes were functioning, right? So once they started moving toward their target, as they started that um, forward displacement moving toward the plate, and their eyes started to drop as their body dropped down, going down the slope of the mound, their visual tracking system just went totally haywire. And what we ended up finding the biggest issue was when they were kind of in this position, was they weren't able to get their head to turn, so they were really only seeing out of the forward eye as they were going through it. And so their depth perception was just all kinds of messed up. So it ended up being a CV problem that was the biggest issue with that patient. Because once we were able to improve the ability to rotate the head to catch the target, to get both eyes involved, a lot of those kind of visual issues, that the target search issues that patient was having, started to go away. So those were two of the more interesting ones, and that's, you don't really come to those conclusions on day one, right? I mean, I'm sure Dave will totally agree with me, and I'm sure most of
Yeah.
you will agree with that too. Those are not solutions that you find on the first day of treating a patient.
Yeah, it's being patient with yourself, and allowing yourself to kind of find it and don't beat yourself up. But like even just simply looking at this here, you can get a sense of in the balance. It doesn't have to be a picture, but in different phases, whether it's the wind-up phase where you're in single leg stance, this could go wrong basically from the foot up. If you can't control the foot, the hip, side joint, lumbar spine, TL junction, anything in there, then the next phases will be off. And what you'll see. But when we talked about here, we talked about foot contact phase is probably what Eric was just talking about in the first case, is that when that left knee planted into the ground and that knee wobbled, it had a significant impact on the shoulder, what the shoulder had to do. Because that needs to be a stable, powerful base to kind of come off of, or else the shoulder is going to have to make up for it, or either in the balancing and centering myself, and now you're out of your throwing phase.
Yeah,
So, you know,
it
think
puts
about
so
these in
much
terms
more
of
stress
rehab.
on.
Hmm?
It puts just so much more stress on the shoulder when you kind of fall into that, like I said, kind of this out here, more
Mhm.
abducted phase versus being in this sort of phase there. But yeah, it's tough. But realistically, guys, you shouldn't be beating yourselves up if you feel like you don't find the primary driver on day one. I mean, it's great when you do, but some of these things can be very complicated, especially, I mean, if you look at this thing, right? We're trying to break down a throwing motion just here on the screen, and that there's what, seven different points that they're already going through here on this. And that's, to be honest, that's a relatively simplified version of this thing, right? There's so many things that have to happen just between things in stride to the cocking phase. And in fact, most experts now say that there's two components to the cocking phase. There's an early cocking phase and there's a late cocking phase, right? And so these things they break down notably even within these different phases here. So complicated movements require complicated thinking sometimes, but we should be able to break these things down into individual components eventually, right? Because realistically, I'm not going to try and pick up where in the thoracic spine somebody can't move by watching them throw. I still
Yeah.
have to sit them down on the table and look at the spine specifically with my different movement tests in order to say, all right, it's T2 that's not doing its part, right? I'm not going to be able to see that just watching them go through a thing. I don't care how slow-mo you go, right? It's not going to happen. So eventually we have to break these things down into individual components, and we should be able to find a lot of the problems just by doing that.
I mean, and you know, with the list we gave you, you should be able to go through it in the shoulder and for a sentence on 1 to 13, right? Okay, here's one thing that would cause a problem at this shoulder. Here's one thing at the foot. Here's one thing at the knee, one thing at the hip. It's essentially this person here. It's like, okay, we look at the late phase. Okay, can't, you know, lack of internal rotation on the left hip. You know, if you can't basically, you know, if you have basically the sublux tip there, mechanically they're going to move around it,
Yeah.
or they're going to drive around it in a very abnormal fashion, which will put stress on the labrum, but it's going to change the shoulder. So you'll
Yeah.
see, and you can think of almost, okay, what at any single joint would do this? You know, okay, late phase landing, okay, can't control the foot, or I have a sublux or potentially sublux talus. Okay, am I following that through as I come down? You know, that's going to throw off how I load. So you can pretty easily kind of come with an argument. So one gives you the idea is that you can look at patients you don't normally look at in movement and at least work through the joint system and see what is the joint giving me? What is it not giving me? And where might it be off that it throws off the shoulder or a hip or another spot? So it's kind of slowing it all down for yourself. And just work through that process a bit. We go through more of these as cases as well. No, that was good. That's kind of what I was hoping for today.
Yeah, that makes a lot of sense, guys. Thank you so much for going through that. I think sometimes I get really caught up in like looking at their movement and I don't spend enough time, like what Eric just said, like you still have to sit them down and assess what's not moving because
Yeah.
I'm not going to see it when it's them, just like, watching them throw or watching them walk or whatever it may be. So, yeah, thank you for reiterating that.
Yeah. It's
You
me
got to
all the time.
go.
It's like,
It's all a funnel, right? You start at that 30,000 foot view and you start kind of narrowing things down until it's just like, okay, now I need to look at this one particular body region, this one particular joint.
mhm.
Once you get there, it's like, well, this should be simple because that's just practice, right? All right, guys, I got to roll.
All right,
Talk to
guys,
everybody next
take
week.
care. Thanks, Eric. Nicely done.